Special guest with us today, Dr. Bill Zollweg. I've listened to Dr. Zollweg's presentation on a couple of occasions. He presents information in relation to addiction, in a very simple manner. So we wanted him to come here today, be videotaped, so that we could get his information out to more people within the communities, the townships, and the villages on charter communications. A little bit of an introduction. Bill has been teaching sociology at the University of Wisconsin-La Crosse. He specializes in social pharmacology, research design, and statistics. He has authored 2 textbooks for introductory sociology and has numerous publications and has numerous published articles on a wide range of topics. He is listed in Who's Who's among American teachers and the Who in America for his outstanding teaching and research accomplishments. Bill has conducted many research projects for the community organizations. His work includes research for the Wisconsin Department of Transportation on repeat drunk driving policy, drug treatment program evaluation for the Cooley Council on addictions, and drug court evaluation. Bill has served on the faculty of the Department of Justice, a National Drug Court Institute, where he conducts training for drug court teams. As a member of the Oxford Roundtable Series on Addiction, Bill lectured there in March of 2008 about his brain injury theory of addiction. Please join me in welcoming Dr. Bill Zollweg to the Monroe County Safe Community Coalition's June 2014 meeting.
Good morning, thanks for having me. She'll get the slide up here and we'll get going on it as fast as we can. So what I'm going to do for you today is kind of give you a history of how our thinking has changed about addiction over the years. First I want to let you know there's no universally accepted definition for addiction. Even today, we still don't have a concrete definition that everybody agrees on. We have, over the years, had 4 competing theories, and I'll talk about each one of these as we go through, but the first one was called the physical dependence definition, and this is the one that's still in use in hospitals today, and it's the one that people go into detox for. Then came along the psychological dependence definition. That one didn't last very long, and I'll show you when we get to that slide. There was some problems with it, and it wasn't very functional on a medical sense. More recently, and this is 2 of the things, the 3 and 4 are the ones that we use when we're assessing drunk drivers. So someone gets pulled over for drunk driving, one of the first things that the court requires them to do is get an assessment about their drinking behavior. And so we use these 3 and 4 today as a way of assessing people's drinking behavior and putting them in categories of either they're an addict or they're a problem drinker or they're just an irresponsible person. And then what I really want to talk about, and hopefully spend the most time on, is a new way of thinking about addiction, and it's called the brain injury definition of addiction. And now I just push the arrow button. For most of the history of the world, there was no definition of addiction, and there was no consideration of addiction. Addiction was just something that people didn't really think about. That is until one of America's founders, Dr. Benjamin Rush, came along. And Dr. Rush was the first one to coin the term addiction. And he, through his title, and I love this, back in the early 1800s, the titles that they had on things were pretty much told you the whole story. You didn't really have to read anything except the title. But his piece was called An Inquiry into the Effects of Ardent Spirits upon the Human Mind and Body, with an account of the means of preventing them and of the remedies for curing them. So that pretty much tells you what the whole piece was about. And he did that in 1819. He's the first one to recognize that addiction passes through stages and progresses through stages. He's the first one to say that alcohol is not just good for people, because In his time, of course, alcohol consumption in the United States was through the roof. We think we have an alcohol problem today. It was nothing. It's nothing today compared to what it was in the early years of America. Just for example, in the early 1800s, everybody in the country aged 14 or over was drinking over 7 gallons of alcohol a year. Today, we're down to 2. And this is one of the lowest, by the way, in spite of our problems that we have, and our problems come from other things to do with alcohol, but we are at one of the lowest points of alcohol consumption in the history of the country today, right now. He's the first one to bring up this notion of addiction, and I like to give him credit for doing that and helping us recognize that alcohol leads to alcoholism. So his definition then led to the physical dependence definition. And this is the idea that when you withdraw the chemical that the individual is addicted to, the body goes through real concrete physical symptoms. You know, you get the shakes, you get the cramps, you get the detox tremors, the DTs, and we put people into detox, and we consider them detoxified when these symptoms pass. It's always had some problems, and one of those is that it's really too restrictive to be useful. So, in other words, by the time a person gets to the point where they're experiencing withdrawal symptoms because of their dependence, they're at a point in the progress of the addiction where it's it's the most difficult point to help them. So we've always tried to look for a definition that gets us somewhere earlier in the stages of the development of addiction. And that's pretty much where we took off from in the 1800s with this definition. Well, and then the other problem is that, abusers of a drug are not included in this definition. So, you can be terribly abusive with a drug, using it all the time, and not be counted as an addict because you don't display these physical symptoms. So it's limiting in that sense, and we have been on a quest ever since the 1800s to come up with a definition that we can all agree on, and that gets us to the point of understanding someone's addiction earlier in the progress of the disease. We moved on then to the psychological dependence definition of addiction. And this is the definition that basically says, if I experience some psychological discomfort because of the removal of the chemical, that means I'm addicted. And so we ask them questions like, do you drink after you've had a bad day? Or do you drink more or less than your friends? These kinds of questions to get at this psychological dependence. And of course, the answer to that question is, well, I don't drink as much as my friends. That is an indicator that you're psychologically dependent on the drug. You always measure yourself next to someone who's worse than you are. That's why every town has a town drunk. Because everybody else that's also addicted buys the town drunk drinks to keep them going so that I'm never as bad as that guy. The definition has a lot of problems. Moderate users could also answer yes to a lot of the questions that are used for psychological addiction. The definition is totally subjective. So we have no concrete empirical measure of addiction using psychological addiction. I use the analogy of I'm psychologically addicted to brushing my teeth in the morning. And if I leave home and I realize I could be 2 miles away from home and I realize, holy smokes, I forgot to brush my teeth, I gotta stop, I gotta turn around, I go back home. Maybe it makes me late for work, creates life problems for me. I'm psychologically addicted to brushing my teeth in the morning. Or as the case in Winona County, Minnesota, a couple of years ago, a guy was before the Judge Damon in Winona County, and he was before the judge for poaching. And his defense to the judge was, he said, Judge, I'm sorry, I can't help myself, I'm addicted to hunting. And so here is the psychological, he gets withdrawal symptoms, you see, if he's not out hunting. So he's got to go hunting or he gets these terrible feelings. The other point is that no difference, in fact, a habit in this definition of psychological addiction is exactly what it is. It's a habit. And some of them are good and some of them are bad. The reason we abandoned the psychological definition is because it's impossible to measure. And so no insurance company was willing to use that definition as a criteria for giving someone funds to support recovery, because we can't measure it in any way whatsoever. So we had to leave the psychological definition behind. And to satisfy those basic concerns of supplying people with funds to provide them with treatment, we moved on to the quantity and frequency definition. So here we ask people, how often do you drink? We ask them, how much do you drink? We try to get at a quantifiable measurement of use. And in this way, then, use becomes equated with addiction on the basis of high frequency and high use. Some of the problems we have here is that, there are so many individual factors that are involved in addiction. If you just use the standard drug of alcohol, a person's habituation has a huge impact on whether or not they display symptoms of addiction. So the state police tell me that when they pull over a real alcoholic, that person can pass the field sobriety test. They can say the alphabet backwards. They practice drunk a lot. An inexperienced drinker has a difficult time passing the field sobriety test. So the portable breathalyzer came along to try to even the playing field, in other words, between a casual user and a habitual user. Binge drinkers don't fit into this definition. Their yearly average might be low, but their pattern of abuse on occasions could actually lead to real addiction, and they don't get counted in this way. There are some other problems with the idea of binge drinking. Binge drinking, like psychological dependence, really doesn't have a definition. We all have an understanding of what binge drinking is, but it's not really a quantifiable thing. Some people say 5 or more drinks in one sitting. What really constitutes a sitting? Somebody can have 5 drinks over the course of 24 hours, and that would count as a binge. Or somebody can have 5 drinks in an hour, and certainly most of us would count that as a binge. But we don't have a real concrete definition of what binge means. We have some problems with this one. I like to use my mom, who's passed now, but she was never very much of a drinker at all. But it seemed like the older she got, the more she liked the wine. And using this definition, my mother would, at 87, would have counted as an addict because she insisted on having a glass of wine every night before bed. She claimed, and I don't have any evidence to refute her, but she claimed it helped her sleep. I'm not sure if that's true or not, but that was her claim. But she drank every day. And she probably didn't start drinking every day until she was 75 or older. But she would count on this definition of someone who was at least an abuser of alcohol because she was an everyday drinker. Most of the OWI assessments now also include a life problems component. And here the idea is that if you've experienced some kind of life problem because of your chemical use, that means you're an addict. So if you develop some kind of medical problem, obviously, you're an addict. If you have some kind of family problem, you get a divorce, or you've been arrested for domestic abuse, if you have career problems, you've lost your job, if you have criminal justice problems, if you get arrested. Lots of people in drug treatment court programs that I work with, lots of people say, listen, you know, this is your third drunk driving offense. Obviously, you're addicted. And that's the definition that people like to apply. Some of the problems here is that there are subcultural and cultural definitions that don't fit this clear problem here. The medical problems that people experience are not a strict per dose problem. So somebody can drink, I don't know, a lot, let's say, for 50 years and never develop any medical problems. Somebody else might drink for just a few years and develop a medical problem. So the injury is not based on the dosage of the chemical that you're receiving. So not all of the people, one of the things that I like to do is talk to people about, say, family problems, and a common research correlation, and this, I use this as an example of poor research, is that juvenile delinquents are the result of divorced families. So divorce causes juvenile delinquents. Well, one of the things in research design we teach all the time is that in order to make that statement, you have to be able to demonstrate that the divorce came before the juvenile delinquents. To my knowledge, there is no research that shows that. We just find a correlation, and we assume that one comes before the other. Well, I've been married for 28 years, and I can tell you, nothing causes more problems among a relationship than how to discipline the kids. So it might be that the juvenile delinquency causes the divorce. It might be completely the other way around. So these life problem things here, divorce, maybe the problem in the marriage causes the drinking rather than the drinking causes the problem in the marriage. We don't have concrete answers to these things, so there are some problems even with the life definition of addiction. So these are the four right now that are competing for dominance in all of our understandings of the concept of addiction. And what I'd like to do is introduce you, and to do this I'm going to have to get into a little bit of neurology and biology. Wes was really complimentary, saying I make this simple, but you know, some of it is not quite that simple, so I'm going to divert here into the not so simple part now. So some of the basics of drugs, the neurology and chemistry here, let's put all this up here. Our brain controls everything about our body. The brain is the driving engine of everything that's human. And in our brain are neurons, and these are nerve cells which send electrical impulses from one neuron to another that control different body parts and different body cells. Neurons, these neurons in the brain, control all of our what are called autonomic functions. These are the things that we do without having to think about them, like breathing and blinking and coughing and sneezing. Those are all autonomic functions controlled by the central nervous system. And they control all of our voluntary functions. So in order for me to be able to do this, the first thing that has to happen is a neuron in my brain sends a signal from a transmitter to a receptor that then sends the signal to this body part that controls my muscles of my arm that allow me to raise my hand. Now, we've known about this for hundreds of years. Stroke patients, stroke victims, one of my really best neighbors had a stroke a couple of years ago, and she can't move the right side of her body. There's nothing wrong with her muscles. at all. What's happened is because of the stroke, blood was cut off from that portion of the brain, which depleted the oxygen in the brain, and without the oxygen, that part of the brain died. And so, no matter how much she does physical therapy, it's not gonna make it so that she can move her arm again. The problem isn't in the muscle, the problem is in the brain. The same thing goes with one of my son's friends had a concussion playing football in high school his senior year. And the concussion actually causes a stroke-like damage in the brain, which fortunately for people suffering from concussions, your brain can recover if you let them rest and don't engage in the activity for a while. But while he was suffering the symptoms of the concussion, he couldn't remember that there was a test that day. He forgot to turn in assignments. If you look at him from the outside, he's perfectly normal. There's absolutely no excuse you can think of for why he's not functioning in a superior way. But the truth of the matter is, he's got a brain injury. And he's going to need some help until that brain recovers. Just like stroke victims, what we know now about stroke victims is that if you can get them back to their life as soon as possible, the brain has an incredible ability to circumvent that damaged area, and other parts of the brain take up for that lacking area. And a person can recover, perhaps not fully, some people do recover fully, but perhaps well enough to continue on with a very high quality life. So what we're talking about basically are psychoactive drugs, and psychoactive drugs have this really peculiar propensity. Alcohol, tobacco, marijuana, cocaine, all of the basic drugs that we know of and you people are helping to ameliorate some of the problems in the community on are psychoactive. And what that means is that the chemical, the active chemical in the drug, has the ability to cross the blood-brain barrier and go straight into the brain. Oh, this is a marvelous thing, a phenomenal thing. Neurologists would love to understand the secret that these chemicals have of crossing the blood-brain barrier. Because if they could, neurologists tell me, they would be able to treat real diseases of the brain in a way that we can't today. So if somebody has a tumor in the brain, gosh, if we could figure out how to get the chemotherapy through and across the blood-brain barrier and right into the brain, it would be a miracle. Treatment would improve 100-fold overnight if we could do that. But we can't. And so we're left really, neurologists I should say, are left with only two options. One is to literally cut a hole or use a hole that's already in your skull to get the chemical in there, and the second is to do brain surgery. And neurologists will tell you that when you cut the skull cap off, pardon me, and get in there, you can't tell the highly functioning part of the brain from the part that's damaged. And so it's an experiment, and usually when they do that kind of brain surgery, I want to keep the patient awake. And I want to, at certain points, say, can you move your right arm? Can you wiggle your fingers for me? Can you talk? Can you hear me? Because I want to make sure that when I'm cutting something out, I'm not cutting out something that's really important. So they want to keep you awake during that surgery. So that crossing of the blood-brain barrier is really important, and that's what makes these drugs dangerous, is because they have this unique ability to almost instantly cross that blood-brain barrier and get right into the brain, which controls every other aspect of how you live your life and how you move. Different routes of administration, of course, result in different levels of blood-brain crossover. So typically, people think that injecting a drug is the fastest way to cross that blood-brain barrier, but that's really not the case at all. In fact, in order for that drug to get to your brain, it has to first be diluted with all the other blood in your body, and then it crosses into the brain. The fastest way to get to the brain is through the lungs. And this is a really strange thing to understand, and still every time when this was first explained to me, I was almost shocked. Still, whenever I think about it, it's really kind of phenomenal. The average human has about 5 liters of blood in them. And so here's what we do, you know, the blood is how we administer drugs. That's why body weight is so important. Whenever you go to the doctor, the first thing they do is weigh you. And that's because if I'm going to give you a medication, it's based, how much I give you, whether it's 10 milligrams or 15 milligrams or 20, is based on how much you weigh. The less you weigh means the less blood you have. And so I give you less drug. The more you weigh, the more blood you have because you have more blood vessels to transverse, and then I can give you more of the drug. So the drugs are based on how much blood is in the body. All 5 liters of blood in your body pass through your lungs every 60 seconds. Every 60 seconds. That means it takes between 2 and 3 seconds for an inhaled drug to get inside your brain. We believe that the method of administration, and you know, we're working diligently to get really concrete answers for you. We're not there yet. We believe that the faster the route of administration, the faster it crosses the blood-brain barrier, the higher the potential is for addiction. Lots of factors are involved, though, and I'll get to those in a second. But lots of factors are involved in that alter that basic formula. The slowest route of administration is ingestion. So when you take a pill that a doctor has prescribed for you, it's going to take at least 30 minutes before that drug will get into your brain and start affecting you. This is why when the police pull someone over, suspected of drunk driving, they give them the field breathalyzer. If the field breathalyzer says that they've been drinking, they take them down to the police station, and they'll generally make the person sit there for at least 20 minutes. I think the protocol is 30. And that's because we know that you probably just had your last drink just before you got in the car. And we want to make sure we get an accurate reading, so we're going to let that alcohol actually get into your system. Now we'll measure to make sure we have the right level. So that blood-brain crossover is a key factor in understanding addiction. This is one of the important neurotransmitters in addiction. This is serotonin, and this is in connection with methamphetamine addiction. So here you have the transmitter, and this is the neuron receptor. And you can see the transmitter sends the signal to the receptor, and the receptor then has a channel here to send the message on electrically to alter the behavior or change the body function from there on out. Most things, and in the body, let me see what I got next here if I want to go on this. In the body, in the brain, there are 13 places in different parts of the brain that neurologists refer to as pleasure centers. And these are specific neurotransmitters and neuroreceptors that are responsible for you feeling happy, you euphoric, really good. And there are lots of things in life that make you feel good. Let me just ask you, what makes you happy? Name one thing.
Bike.
Biking, great. What makes you happy?
Running.
Running, all right. So we got two of the same. What makes you happy?
My family.
Family, great one, I love that.